So today's webinar is titled Farm to Table, Serving Up Antimicrobial PK/PD Insights and Dosing Pearls. My name is Mary Joyce Wingler and I will be the moderator. I am an antimicrobial stewardship pharmacist at the University of Mississippi Medical Center, and we're so excited that you're here today. So today, our educational webinar is going to focus on the fundamentals of infectious diseases pharmacotherapy for learners, early career practitioners, and anyone who'd like a refresher on the fundamentals. If you follow SIDP on social media, we really appreciated your input on this program. We asked what you wanted to see, and that's what's going to be included in our session today. The most votes were for weight-based dosing, obesity adjustments, and therapeutic drug monitoring considerations for antimicrobials. And again, we're very excited that y'all gave us that input, and that's what we're planning to talk about. So on to our speaker, we're very excited to have Dr. Lena Meng today as our faculty speaker. She is a member of the Stanford Antimicrobial Safety and Sustainability Program and serves as a lecturer at the Stanford University School of Medicine. She earned her Doctor of Pharmacy degree from the University of California, San Diego, and completed her PGY1 residency at UCSF and a PGY2 critical care residency at Stanford. Since joining the antimicrobial stewardship team in 2015, Dr. Meng has focused on improving antimicrobial use and stewardship initiatives, and she actively precepts pharmacy residents and infectious diseases fellows, and previously served as the PGY2 infectious diseases residency program director at Stanford. Her interests include clinical pharmacokinetics and pharmacodynamics, particularly in the critically ill population, as well as medical education. The learning objectives for this activity are listed on this slide. We'll be discussing the PK and PD of antimicrobials and their application to patient care, key concepts and principles of the bioavailability of oral beta-lactams, key principles of weight-based antimicrobial dosing and obesity, and then applying all of those to different patient scenarios. So now I will turn it over to Dr. Meng.
Hello, everyone, and thanks for joining. I'm excited to speak with all of you today. Thanks for the introduction as well. We have a great set of objectives today, so I will do my best to walk you through high-yield applications of PK/PD and point out dosing pearls in special populations. Today, I will use 3 cases to achieve our objectives. But first, let's get started with a review of select PK/PD principles that are relevant to our talk today. First, why is antimicrobial dose optimization important? Not only has it been associated with achieving clinical success, but also in reducing the emergence of resistance. So it's not only important to select the right antimicrobial, but to also identify the optimal dosing regimen that is consistent with its PK and PD information. Pharmacokinetics refers to what the body does to the drug, and pharmacodynamics refers to what the drug does to the body. There are 4 components of pharmacokinetics: absorption, distribution, metabolism, and excretion. Volume of distribution can be linked to loading doses in the following slide. Volume of distribution is defined as the way it relates to the total amount of drug in the body to plasma concentrations. Important to this talk today, volume of distribution is the principal determinant of a loading dose. This is also described in the equation in the blue box on the right-hand side, where an IV loading dose is equal to the target concentration times the volume of distribution. Volume of distribution is influenced by a drug's physiochemical characteristics, its ability to cross tissue membranes. These include factors such as molecular size, ionization, and lipid solubility. Loading doses are important because they help us achieve rapid attainment of target concentrations at our site of infection. Increased volumes of distribution can occur in obese patients because of higher adipose and lean muscle mass. In critically ill patients, it can be increased due to third spacing and fluid resuscitation and other factors that I will describe in a few slides. Now we'll talk about clearance and how it relates to maintenance doses. Maintenance doses, and not loading doses, are mostly driven by total body clearance. Total body clearance, then, is the sum of clearances by each of the eliminating organs. For most antibiotics, this is primarily the liver and kidneys. Increased organ mass in obesity, for example, may increase clearance. Now we'll talk a little bit about elimination half-life as it is related to volume and distribution through these 2 equations. First, the elimination constant is equal to the clearance divided by volume of distribution. And then half-life is equal to 0.693 divided by K. When you're evaluating literature, it's important to note the patterns of change between this ratio of clearance to volume of distribution. Because these parameters can be altered to different extents, half-life can be prolonged or shortened, and that therefore can impact your maintenance dosing regimen. Many critically ill patients have severely altered pharmacokinetic characteristics, which may reduce the likelihood that they will achieve the appropriate PK/PD targets. Some of these factors include not only an increased volume of distribution from third spacing or altered protein binding, but also organ support, so renal replacement therapy or ECMO. Patients can be hyperdynamic with an increased cardiac output, which can then increase clearance of drugs. And lastly, we are all familiar with the frequent renal and hepatic dysfunction in our critically ill patients. In addition to various parameters that can be altered in critically ill patients, we can have additive changes in patients with obesity, defined as those with a BMI of greater than or equal to 30 kilograms per meter squared. As I mentioned before, increased volume distribution, for example, is common and expected in obese patients due to increased excess mass. You might expect larger changes with drugs that are lipophilic compared to hydrophilic drugs. Because obese patients may have increased kidney mass, you might then expect increased renal blood flow and increased GFR, which may then result in increased drug clearance, especially for drugs that are heavily renally cleared. There are other comorbidities associated with obese patients that may lead to decreased clearance, however. These include age, obesity-related nephropathy, vascular disease, non-fatty liver disease, etc. These are described in this figure shown here. There are several elements of pharmacokinetics and pharmacodynamics that are shown on a continuum here. The first three elements relate to pharmacokinetics, the dosing regimen, the concentration in the serum, and the concentration at the site of infection. Pharmacodynamics then relates to the last two elements, where it relates to the concentration at the site of infection and the biological effect. When we're dosing antimicrobials in particular, and in contrast with other drugs, we have to also incorporate consideration for the bug. Most of the time we're thinking about the host and the drug, right? But with antimicrobials, this has one additional factor that's represented in this triad that I'll use today when we go over our cases. When we look at relationships between the host and drug, this is described by pharmacokinetics. The drug can exert adverse effects onto the host in a reciprocal relationship. When we look at bug and drug relationships, this is described by pharmacodynamics. The bug can also exert resistance mechanisms back at any drug that it is exposed to. And lastly, we can look at the host-bug relationship, where we must consider the site of infection and the immune response to the infection. A large emphasis in this talk today will relate to drug dosing design in relation to MIC considerations. So I wanted to define this term in this slide. MIC is the lowest concentration of an antibiotic that visibly inhibits microorganism growth. Please note that this is in the test tube, it's in vitro, so there are several limitations to this number, this value. First, it does not consider the time course of antimicrobial activity, including things such as post-antibiotic effects. Secondly, it doesn't mimic physiological conditions. There's no intact immune system in that test tube. And lastly, when our microbiology lab tests the plates, you should expect, it's not unexpected to have a plus or minus 1 twofold dilution. So for example, an MIC of 2 that is reported might on repeat testing show a value of 1 or repeat value of 4. Breakpoints are set globally by 3 main organizations. In the United States, these are CLSI and FDA, and in Europe, UCAST. Here are the links provided. These organizations periodically review MIC trends and epidemiological trends, PK/PD data, clinical data whenever available, and they make recommendations on what MIC values would be counted as susceptible or likely to treat an infection and which would be considered resistant. Now we can relate pharmacokinetics to MIC by looking at pharmacodynamic measures. We have a concentration time curve here with the MIC displayed in the dotted green line. Drugs are generally classified into 3 PD measures, those being those exerting concentration-dependent killing, which means that the higher your concentration achieved relative to the MIC, the more bacterial killing occurs. Secondly, some drugs are classified as having time-dependent killing, meaning it doesn't matter how high your concentration is relative to the MIC, we just need to maintain a concentration even if it's barely over the MIC, for as long as possible to exert the best bacterial killing. And lastly, we have AUC to MIC, which incorporates both of these components, both concentration and time, which is represented by the gray shaded area. In this chart on the left, I've listed a couple example PK/PD measures, and we'll talk about how they relate to dosing design. Depending on different drugs or drug classes, you can see that they have various PD parameters for effectiveness, and they have individualized target drug concentrations based on PK/PD studies and sometimes clinical studies. A dosing tip here is that your dosing scheme should be tailored to meet your pharmacodynamic target. For example, drugs such as daptomycin that can exhibit concentration-dependent killing should be dosed as high as tolerable and safe. Whereas drugs such as beta-lactams that exhibit time-dependent killing may require frequent dosing and or prolonged or continuous infusion to maximize their killing. A chart displaying how long the time should be above MIC for various gram-positive and gram-negative agents. You can review that in the handout. Okay, so we'll move on to percent of time above MIC. This slide will illustrate how different infusion strategies can overcome high MICs. Okay, here we have a concentration time curve. On the x-axis, we are talking about hours. So we have 5 hours displayed here, which will represent one dosing interval. First, let's go over how MIC can impact how long the time, the concentration can remain above the MIC during a given dosing interval. So we have, let's say we have your first isolate here with an MIC of 0.5, and we are administering a traditional infusion over 30 minutes of a beta-lactam. You can see that our concentrations remain at target above the MIC about 50% of the time here. However, if we have a second isolate with an MIC of 1.0, you can see that this number drops, this target attainment drops to only 30% of the time in this dosing interval. Okay, so let's look a little bit closer at that isolate number 2 that had a higher MIC of 1. Let me bring up the concentration time curve again. Okay, there's our isolate with an MIC of 1, and that's our 30-minute infusion that achieves the ideal concentrations above the MIC for 30% of the dosing interval. So now we can see how using a prolonged infusion may be advantageous. With an 1-hour infusion, 2-hour infusion, and here shown in blue, a 3-hour infusion, you can see that you increase this target attainment to 60% time above MIC. Continuous infusion then showing kind of the maximal benefit. You're achieving your target concentrations 100% of the dosing interval. Okay, so since we will have an upcoming case on piperacillin tazobactam dosing, we can review this Monte Carlo simulation plot. This figure essentially plots out the likelihood that you will achieve a pharmacodynamic target based on the MIC of an organism and concentrations expected with different antibiotic doses. On the x-axis, you have MIC, and on the y-axis, you have the probability of target attainment. In terms of what you're looking for probability of target attainment, this number is generally 90%. That's shown by this dotted red line. Now we'll look at an isolate at the breakpoint of 16, MIC of 16, that's the blue vertical line here. So you can see in the figure, this Monte Carlo simulation, that only one dosing regimen, right here with the open circle, will achieve your target, greater than 90% chance of target attainment. That would be 3.375 grams every 8 hours infused over 4 hours for each dose. So that's where our standard anti-pseudomonal dosing of tazo comes from. Now we'll move to a first poll question for today. Which drug or drug class exhibits time-dependent killing, thus requiring frequent or prolonged continuous infusion administration? Daptomycin, fluoroquinolones, beta-lactams, or fluconazole? Okay. Sounds like you guys are well aware of beta-lactams and their PD targets. Everyone answered this one correct. Let me move on to a second question. True or false, obesity and critical illness lead to altered pharmacokinetics of antibiotics? Please select one, true or false. So most of you guys answered true for this, and that is correct. There are many PK derangements in these populations, and they can occur in combination. So we are going to start case 1 to demonstrate dosing strategies using piperacillin tazobactam as an example to demonstrate these principles. So for the next 2 polling questions, I'll ask them once now, and after I go through a few slides on this topic, we will ask you these questions one more time. First question for this case is, there are high-quality data to support increased doses of piperacillin tazobactam in obese patients. True or false? We're seeing more favoring false, and good number thinking this is true as well. So we will definitely go over some data for this. And this question, we have a 40-year-old female with a BMI of 40 with Pseudomonas aeruginosa growing in blood cultures. The MIC is 16, creatinine clearance is 110. The team is asking you for recommendations on initiation of piptazo. Which dosing strategy would you recommend? 3.375 to 8 hours administered as an extended infusion. B, 4.5 grams Q 6 hours as an intermittent infusion, or C, 4.5 grams Q 6 hours given as an extended infusion, so that being the most aggressive regimen. I have 22% recommending kind of a standard anti-pseudomonal dose, 3% favoring it given as a traditional infusion, and 75% majority favoring a more aggressive dosing regimen. And move on to some slides then on this topic. So here's a framework I'd like to present today to optimize dosing in obese patients. First, familiarize yourself with data in obesity. This is a quick PubMed literature search, pulling up review articles, going to your standard drug references and databases, Micromedics, Lexicomp, and seeing if there's anything there. Secondly, pay attention to the drug's PK/PD profile. How is it metabolized and excreted? Is it highly protein bound? Don't put too much weight in lipophilicity, molecular weight, or it being having static or cidal killing. Usually these factors are one of many different variables that may or may not ultimately impact your final dosing recommendation, or they may not, in many clinical studies, show any clinical benefit. So they're not easy to predict dosing based on these factors alone. Number 3, identify concomitant factors that can alter PK in your patient. So is your obese patient also somebody with AKI? Do they have severe hepatic dysfunction? Do they have hypoalbuminemia? Remember, there are many factors that can be compounded to alter PK. And what you should keep in mind is, are these derangements enough to affect the final dosing regimen? Would you be able to meet your PD target? Number 4, safety, because a lot of us really want to push the dose on a lot of these patients. So how high can you go? What's the upper limit of normal for dosing? Can you safely meet your pharmacodynamic target? Number 5, consider your margin for error. So you should factor in things like the severity of infection, your site of infection, host factors. Is this meningitis or bacteremia, or is this something like UTI? Also consider immune status. Is this a patient with an intact immune system or severe neutropenia? And lastly, are there alternative agents that are likely to be effective with better data or a better match for the treatment of this particular organism, MIC, and infection type? Back to our triad, the drug at hand is piperacillin tazobactam, highly renally cleared, exhibits time-dependent killing, and our bug is Pseudomonas aeruginosa with an MIC of 16 in the bloodstream. So those are kind of the variables that I'm looking at. Now, putting that together with any concrete data, there have been a number of small studies on this topic. However, there's huge heterogeneity. The case studies are also of low quality or low-level evidence. They comprise of case reports, PK/PD studies, and very small clinical studies. Furthermore, the patient population studied range from trauma patients and medicine ward patients to critically ill patients, including subsets with renal insufficiency or those on CRRT. A lot of these studies consistently showed an increased volume of distribution of piperacillin, and that's not unexpected given their increased body mass, adipose, and lean muscle mass. For other parameters, though, such as clearance, there were conflicting PK changes reported in obese. You'll commonly see that in literature. Some studies say they saw decreased serum concentrations, others say increased, so it's really variable. One pertinent paper I want to highlight is that with beta-lactams, with piperacillin in particular, there was large intrapatient variability seen in critically ill septic obese patients. This is a theme seen not just with piperacillin, it's also the case with meropenem and cefepime, and certainly for those on CRRT. It could be that, as we mentioned before, there's so many variables in critically ill patients, like CRRT effluent flow rates, for example, can cause or contribute to this variability seen. The last important factor I'd like to highlight today is that one should pay attention to the creatinine clearance, especially for drugs that are highly renally cleared. For piptazo in particular, higher creatinine clearance, greater than 100, was a risk factor for inadequate PK/PD target attainment in obese patients. Furthermore, in a separate study in obese patients, prolonged and continuous infusion strategies were attempted to try to overcome these limitations, and it was adequate, but only up to an MIC of 8. recall that the break point is 16, so we still have to pay attention to the MIC when we're treating obese patients. Furthermore, these extended infusion strategies worked better and could overcome these issues, but only up to a creatinine clearance of 150. So again, we see this theme of when you start reaching really high renal clearance in your patients, you're not as likely to achieve your pharmacodynamic target. Okay, so what do we do in the front lines when we're in a hurry in the middle of rounds? Well, I think one great addition, one feature that Lexicomp has added in the last year, I want to say, is that they added a section in the dosing section for obese patients. These recommendations are based on best available evidence, which generally in obese patients is not great. It's usually case reports and maybe small PK studies. These recommendations are based also on clinical expertise by an editorial team that consists of great clinicians that have published in this space. Whether you're using a reference like Lexicomp or you're pulling up the review article for more information and nuances, you'll still see the same themes. Because the literature is so heterogeneous, you'll see you can extract certain themes out of it, but there's different approaches that people may recommend. But common threads include higher doses needed for those with life-threatening infections, those with pathogens that are close to the breakpoint for susceptible, patients with extreme morbid obesity, usually that's defined as a BMI greater than or equal to 50, and those with elevated creatinine clearance, either augmented renal clearance or even, in this case for Peptazo, a creatinine clearance was identified of 100 being kind of a threshold for caution. One other thing I like to teach my trainees is that dosing can be dynamic in obese and or critically ill patients. You can start off with something more intensive until the infection is under control. So, maybe you're waiting for source control or maybe for blood cultures to clear. You might start off aggressive and then kind of scale back and de-escalate your dose. Certainly, if you're talking about a patient that moves from the ICU to the floor and no longer has factors that might have altered their pharmacokinetics while in the ICU. Okay, so now we'll return to our case where most of you selected answer C followed by answer A. So I'll let you guys vote on this one more time. After we've gone through our slides, majority has shifted their answer to answer C, 4.5 grams every 6 hours administered as an extended infusion. And that's, again, because this patient had elevated MIC at the break point, obesity, creatinine clearance that was moderately high, so that a high dose would be justified, at least initially. The second question was, there are high-quality data to support increased doses of piperacillin tazobactam in obese patients. True or false? A little bit more shift of votes towards false. So in this answer, I want to highlight that while there are studies, there are quite a number of studies in Peptazo and obesity, the level of evidence is still quite low. There weren't, there's no randomized control trial, for example, for any antimicrobials for dosing optimization in obese patients. Again, you're going to see a lot of case reports and small studies, sometimes with 10 or 20, 30 patients. So that's part of the challenge in finding and interpreting the data and applying it to your practice. But hopefully the references I showed can kind of be a starting point for you and provided a framework for considerations when you're approaching these patients and their dosing design. Okay, so now we're going to move on to our case number 2. I've chosen oral beta-lactams, specifically in the treatment of gram-negative broad bacteremia, to illustrate a couple more applied PK/PD principles. Okay, and if you're coming into this talk with an understanding that all oral beta-lactams are the same, I hope that you guys can be more nuanced and refined in this consideration, at least as it pertains to the treatment of bacteremia. Okay, I will start off with another case of bacteremic UTI. It's a 73-year-old female admitted for fevers, dysuria, started on ceftriaxone. Blood and urine cultures grew E. coli with a susceptibility profile on the right-hand side there. The serum creatinine is 1.8, creatinine clearance is 33. The patient's imaging did not show evidence of pyelonephritis, stones, or abscess. After 3 days of appropriate treatment on IV antibiotics, the patient is afebrile, clinically improved, and on a regular diet. The team is asking for your help transitioning to an oral antibiotic, an alternative to fluoroquinolones and trimethoprim sulfamethoxazole given for AKI. They asked specifically about oral third-generation cephalosporins, such as cefodoxime. Let's go to a polling question. Are oral beta-lactams effective in uncomplicated bacteremic UTIs? Most of you answered B, yes, if you use select dose optimized oral beta-lactams, and a second popular answer was answer A. So let's go over the answers or some of the supporting data for this topic. I think in the front lines you are commonly, it's common to hear practitioners select oral beta-lactams with high oral bioavailability. So usually, amoxicillin clavulanate and amoxicillin come up in that discussion, or cephalexin. Ceftazidime, third generation cephalosporin comes up as well, but this one only has kind of moderate oral bioavailability. And lastly, ceftonir as the worst, it's about 25%. Okay, but it's a pitfall to focus solely on absolute bioavailability. It's only one piece of the puzzle. A better question to ask is, can this antibiotic achieve pharmacodynamic targets? So how do we assess this? Well, can the dose be optimized relative to the organism's MIC? So we're going to talk about that in some detail in the coming slides. Okay, first, let's look at oral cephalosporins, pharmacokinetic profiles. Since our case is on bacteremic UTI, the relevant components include the maximum concentration, protein binding, half-life, and urinary excretion. You can see that some of the first generation cephalosporins here, cephalexin and cefadroxil, have the highest maximum concentration achieved, whereas the third generation cephalosporins have the lowest. However, keep in mind that these have to be interpreted relative to their breakpoints. Each of them have different breakpoints listed in the footnote here. But still, as we keep moving to the right of this chart, you can see that all of the oral beta-lactams have a very short half-life. And lastly, in terms of urinary penetration, again, cephalexin and cefadroxil have the highest, whereas third generation cephalosporins have the lowest. Okay, so that's just one slice of dosing determination. Is just understanding its pharmacokinetic profile. Okay, now we have to link it to MIC and the likelihood of pharmacodynamic target attainment. Mogul et al. Did this type of analysis in a publication that's really helpful and practical. The oral cephalosporin that achieves the best likelihood of pharmacodynamic target attainment, that would be cephalexin, dosed at 1 gram Q6 hours, so higher than normal. You can see here in these bottom boxes that you can achieve the pharmacodynamic target for most common MICs, that's MIC of 4. However, with ceftazidime, even when dosed at 400 milligrams every 12 hours, you can achieve only up to 73% of your desired target attainment. So for this one, it depends on your MIC. When you're dealing with an isolate with a lower MIC, you can achieve your targets, but at higher MICs, you're only achieving like 39% or less of your target attainment. Ceftonir performs the worst. At best, it only achieves the pharmacodynamic target attainment 17% of the time. Now we'll look a little bit closer at cefadroxime, since this is what the provider in our case has asked about. Susceptibility and MIC testing for cefadroxime is not routinely performed at many institutions. You can infer cefadroxime susceptibility from ceftriaxone IV, but not MIC data. Ideally, we would want to confirm the MIC for bloodstream infections. The CLSI breakpoint for susceptible is 2, but cefadroxime, even when maximally dosed at 400 milligrams twice a day, only meets pharmacodynamic targets for isolates with MICs up to 0.25. That's not sufficient. Additionally, when we look at clinical data, many of you are familiar with the multiple publications that have come out in the last few years supporting the use of oral beta-lactams in bacteremia. But please note that when you pull up the appendix and look really closely, most of these agents used are amoxicillin clavulanate followed by cephalexin. Cefadroxime kind of falls in the middle, and I think ceftonir is like very, very rarely used. So there are differences, and they should not be all kind of applied blanketly. So all in all, with cefadroxime, the maximum dose may be insufficient for bloodstream infections, even if reported as susceptible or considered susceptible. In the absence of confirmatory MIC values, please use caution if selecting cefadroxime for enterobacterales bloodstream infections. Ceftonir, I want to talk about ceftonir today as well because, it's dosed only twice a day. It's widely available in pharmacies. It comes up a lot, at least at my institution. It's another third-generation cephalosporin. When we're talking about its use in gram-negative bacteremia, however, if you look more closely at the PK parameters on the green table on the left, you can see that the maximum concentration is 1.55 after a 300 milligram dose. It's moderately protein-bound, and its half-life is very short, 1.5 hours. So considering that the CLSI breakpoint is already 1, and your maximum concentrations are 1.55, after one half-life, you're already below the MIC of the organism. So in this case, just even eyeballing the kinetics of this one would not be favorable in gram-negative bacteremia. It's unlikely to meet your pharmacodynamic target throughout the dosing interval. Furthermore, there was a study by Mack et al. That studied clinical outcomes in bacteremic gram-negative UTIs, and when they did a subset analysis on septenere recipients, there was a signal for worse clinical outcomes. This included increased readmission to the hospital with UTIs. So another oral beta-lactam I'd like to talk about today is amoxicillin. High dose 1 gram Q8 hours of amoxicillin is estimated to achieve greater than 80% target attainment in organisms with MIC of less than or equal to 2. The CLSI breakpoint for susceptible is 8. So this is another instance where you do want to look at the MIC more closely. Monte Carlo simulations suggest that even 1 gram Q8 hours is insufficient for susceptible organisms with MICs of 4 or 8. One reference I'd like to impart on the audience today is this publication in OFID in 2021. It's a guidance on oral beta-lactams for uncomplicated gram-negative bacteremia. It incorporates a lot of the points that I had talked about today about considering the pharmacokinetic profile of the oral beta-lactam, the MIC considerations, and it provides suggested dosing schemes. The second resource I'd like to invite anyone to use is freely available from my institution. It's the De-Escalation Guide for Gram-Negative Rod Bacteremia, and it includes not only fluoroquinolones and high-dose trimsulfa, but also oral beta-lactams that we discussed today. Now let's go back to case 2. For this case, the pharmacist responded to the team that they do not recommend cephalosporin or third-generation cephalosporins. After review of the amoxicillin MIC of less than or equal to 2, they recommended this regimen instead, amoxicillin clavulanate 875 over 125 milligrams TID to complete a 7-day course. And now we can go back to our polling question. Are oral beta-lactams effective in uncomplicated gram-negative bacteremia? Please select 1. Yes, treat primary infection and the bacteremia secondarily. Yes, if you use select dose-optimized oral beta-lactams, or no. Great, so most of you got this right. So again, the take-home was that there needs to be more thought and scrutiny of the PK/PD profile when selecting oral beta-lactams in gram-negative rod bacteremia. So you guys, I think you guys all achieved that objective. Okay, so we will wrap up with case number 3. We'll talk about weight-based dosing in obesity and susceptible dose-dependent. We'll use daptomycin as kind of an example case drug. Okay. Case 3, we have a 50-year-old patient, 100 kilograms, BMI 35, with vancomycin-resistant Enterococcus faecium bloodstream infection with a daptomycin MIC of 2. What daptomycin dose do you recommend? You can assume normal renal function. Okay, so since we're now talking about weight-based dosing, it's relevant to then circle back to volume of distribution. I will talk about it, some key points specifically as it relates to obese patients and considerations for total body weight or use of adjusted body weight. I will leave you with this to read and break down on your own time, but I think what I want to advise on is that when you're determining which body weight to use for weight-based dosing, you can compare volume of distribution in non-obese patients and compare it to weight-normalized volume of distribution in obese. If these are the same or similar, this suggests that total body weight is appropriate to use. It means that your drug requirements are likely to scale more proportionally with body weight. Dosing of drugs that do not enter adipose tissue well, however, as with hydrophilic drugs, may warrant use of alternative weight descriptors, mainly adjusted body weight instead of total body weight for calculations. And you wouldn't necessarily know this right away. You would, when you're looking at literature, pharmacokinetic literature that describes VD changes, that's when you would be able to discriminate what's an appropriate dosing weight. You have to look at weight normalized VD, which is VD over total body weight, and compare that to like a normal VD. Now with daptomycin, which dosing weight should we use in obesity? Obese patients, in previous reports, obese patients had significantly increased Cmax, AUC, VD, and clearance. But once again, once they normalized these values to total body weight, they found that these increases were no longer seen or diminished. In some cases, they were even decreased. So this suggested that there's incomplete distribution of drug into excess body tissues in obese, and that adjusted body weight would be more appropriate. Further, after this observation, further PK/PD studies were performed and clinical studies as well, which I have simply summarized in the references. There's more out there if you PubMed them. And actually, as of last week, there was another clinical trial of over retrospective review of over 1,200 patients where use of total body weight with daptomycin 10 mg per kg led to really high rates of rhabdomyolysis and CK elevation. So it's just, there's still ongoing research, but they're more and more just kind of supporting the same thing, is that adjusted body weight is safer to use without jeopardizing clinical outcomes. So all in all, when dosing daptomycin in obese patients, especially when you're using higher doses, it's important to then switch over to adjusted body weight. Okay, now I want to close out with a discussion on susceptible dose-dependent isolates. For enterococcus infections treated with daptomycin, there is a category of susceptible dose-dependent dosing for enterococcus faecium specifically, so not faecalis or other species. So if you have E. faecium infections, these should be dosed at 8 to 12 mg per kg every 24 hours, not 6 mg per kg. This information provided by CLSI was based on PK/PD modeling and clinical data. There was a concern that E. faecium with MICs of 1 harbor mutations, which can lead to high-level daptomycin resistance. Higher doses are thought to prevent or slow down the emergence of this type of resistance. That's why this SDD category here was designated for E. faecium with daptomycin. It's really a flag to tell you to dose higher than normal. Susceptible dose dependent conveys that a higher dose may be needed for isolates with MICs that fall in this category. Isolates in this category would be expected to have the same clinical response as isolates in the susceptible category if higher drug exposure is achieved. So higher drug exposure can be achieved with higher doses, more frequent dosing, extended or continuous infusions. Again, remember to link this optimization of drug exposure to the type of PD profile, like concentration dependent or time dependent killing or AUC dependent killing. That will dictate how you scale your dose. CLSI has specific recommendations for dosing for certain bug-drug combinations with higher MICs. So I have given you the example of E. faecium with daptomycin, but here are 3 other notable examples. Cefepime for Enterobacterales with an MIC of 4 to 8 should be dosed 2 grams to 8 hours over 3 hours. Piptazo treatment in Enterobacterales with MICs of 16 should be dosed 4.5 grams every 8 hours or every 6 hours over as extended infusion. And lastly, fluconazole, when used for the treatment of C. glabrata infections, for isolates with MICs of less than or equal to 32, should be no less than 800 milligrams every 24 hours, not 400 milligrams. Analogous to daptomycin and E. faecium, none of these isolates would be considered susceptible. All C. glabrata is susceptible dose-dependent when we're dealing with fluconazole. Therefore, the minimum dose for all C. glabrata infections when using fluconazole is 800 milligrams every 24 hours. Okay, so circling back to our case with E. faecium bacteremia and daptomycin dosing weight, we are going to recommend 8 to 12 mg per kg using adjusted body weight, which comes out to 664 to 996 milligrams every 24 hours. Okay, and that concludes all 3 cases today. I will leave you all with takeaway points here. Please use the suggested framework for obesity dosing. Be aware of differences in antibiotic PK/PD and effectiveness in relationship to the site of infection, the pathogen, and MIC. Note differences of drugs within the same class, and also pay attention to transient or chronic host factors. So these are kind of summarized so they can be encapsulated in this triad on the right-hand side here, this figure. And lastly, this is more of a tidbit for assessment of literature on this topic, relate PK parameters to dosing impact by linking loading doses and dosing weight to volume of distribution. And when you're looking at impact on maintenance doses, think about clearance. Okay, I'd like to acknowledge the rest of my stewardship team at Stanford for their assistance in the content of these slides.
Thank you, Dr. Ming, for an excellent presentation. My name is Liz Chandler, and I'm an ID Pharmacy Clinical Specialist at Gold Coast Medical Center in Fort Myers, Florida, and I'll be moderating the Q&A portion of this presentation. So just to start off with one question we have here, several of the PK/PD recommendations in the literature are based on the exact MIC of the organism. So how would you approach some of these scenarios if your micro lab only reports the susceptibility interpretation without the MIC?
Yeah, that is always a challenge. It comes to mind with, I'm thinking of like augmentin, for example. Sometimes, or we used to report MICs of less than or equal to 8, but we want to confirm that the MIC is less than or equal to 2 before using augmentin. I can tell you about my practice because this is obviously challenging. Like if you cannot find an alternative agent with more definitive information on like MIC and dosing strategies, then I kind of just look at the case and the infection. Like, we treat so many bacteremic UTIs here, and I'll consider things like how many days of active IV therapy have they already received. If this is a 7-day course and they've already gotten 5 days, I then, to me, it's lower risk to then continue the course 2 days of, augmentin in that example, to finish the course and just, if the patient has any residual symptoms or issues, then they will report that back to the provider. Well, that's the one example I can think of right now. I'm happy to email out anything else I can go about, but it's kind of, I think it depends on the infection type, what treatment course they've received already, obviously like how complex is the infection of the patient, but hopefully that example can give you some ideas.
Excellent. We have one question here regarding daptomycin. So is there a total dose of daptomycin that should not be exceeded when dosing the drug in obese patients?
There is not a hard cutoff. I think it helps a lot when you switch over to adjusted body weight. I don't think I've ever used more than 3 vials, 1,500 milligrams in practice. Even 2 vials to me is like a big dose for most patients, even, for obese patients using adjusted body weight. But, in terms of toxicity, there are certain troughs or levels, blood levels, that would correlate to an increased risk of CK elevation and rhabdomyolysis. However, practically speaking, it's just not something routinely performed, daptomycin, TDM. So it's, I think if you're using higher doses already, especially if you have renal dysfunction, you're already on statins, that's probably someone to monitor more closely, check more frequent CKs and renal function. I think that's just more vigilance, but I don't have a textbook maximum dose that I can recommend in obesity.
Excellent. And maybe one more quick question, there's quite a few questions here that we don't have time for about oral cephalosporins. And so just a general question asked here was any additional resources you could recommend for using susceptibility data as a surrogate to oral cephalosporin selection?
So with that, when we're inferring susceptibility, there's publications on inferring like ceftriaxone susceptibility, oral cephalosporin susceptibility based on ceftriaxone for bloodstream infections. It depends on what source of infection you're using. If you look at CLSI, there's comments on the right-hand column of each drug-bug combination, and it will tell you like which, if there's any caveats, like, you don't extrapolate everything for meningitis, for example. You have to be really careful with that. But for UTIs, even there are restrictions for how you can extrapolate. So I think, this is a common question that our providers commonly ask ID pharmacists to help them kind of tease out. There's not one easy answer. But I would recommend, like, if you don't have a resource or access to an ID pharmacist, you can look at CLSI and see if there's any comments there. And then secondly, you might have to do like a PubMed search on, extrapolation of susceptibilities.
Excellent. Well, once again, I would like to thank you, Dr. Meng, for a great presentation. Following this session, you will receive an evaluation to complete, so please take a moment to let us know your thoughts.